So moment you have to be able to detect problems when they happen and take remedial action immediately. So I can implant this into the bag. As you can see, it's a multifocal IOL. And because I've done a posterior rhexis, I have absolutely no care in the world that that's going to extend. So I can put it wherever I want in the bag. And so this I'm just showing to the younger people in the audience. This is, you do this in every case, because when you come to premium IOLs, you cannot just practice this in premium IOLs. So try to do this in every case of PCR you have. And it's actually very, very easy to tear the posterior capsule compared to the anterior capsule. There are no zonules pulling on it, and it's a much thinner capsule, the posterior capsule. So you can, and just a small bit, that's it. Very, very small. You don't have to make it large. And wherever, it doesn't always have to be central. Sometimes even slightly peripheral one, you can do that. And the advantage is you can implant any sort of IOL in the, so this is not a premium IOL, this is an acrifold. But that you just practice it on any type of lens, any type of. So this was a large PPC. I was very, very sure that the PC will open up here. But the patient was insistent on a multifocal IOL. So this is something that I could do at that time. I'm not sure what I'll do now, because I'm not even sure you get 3-piece multifocal IOLs. At that time, you got the 3-piece Technis. So here there is vitreous. I'm doing the vitrectomy. So do not try to aspirate anything when there's vitreous in the anterior chamber. So do a vitrectomy, anterior vitrectomy. Once that is done, you can actually aspirate the cortex very, very easily, because there's no vitreous coming to the port. And here it was a large, and as you saw, the PPC was very eccentric. So there's absolutely no way I could have got away, and it was too large a PCR to do a rhexis. So once that is done, but here I had planned for a 3-piece multifocal lens. It's a Technis 3-piece. And this has been, these 3-piece multifocals have been a savior so many times in the past. So now if I see this, I will probably tell the patient that we will do a multifocal if it's possible. And I've done it also in the recent years. Otherwise, I'll just choose whatever IOL is best for the situation, for your eye, for the long term. I'm not looking at what you will see tomorrow, but I'm thinking of 10 years ahead also. And most of them agree with that. So this was a 3-piece multifocal, and I could do a capture in the rhexis also, an optic capture. So this is going to remain very stable. And because I've done a capture, the power also doesn't really change. So that is one side captured, and now I'll capture the other side also. And this was a sort of, sorry. Oh, this doesn't play, so we'll just skip that. So that was actually, I'll just tell you about it. There was this Roman Catholic padri who had come, who had an injury to the eye while he was playing shuttle badminton. And he had a sort of a subluxated cataract. So this was the time I had access to a femtocataract system, FLAC, so I did that. And there was significant subluxation on one side. The rest was all right. So actually I planned to do a CTS through Hoffman's pockets. And actually on one side I had made a cut, instead of doing it with a blade, I had made a 300 micron cut with the femto, a straight cut there, like an LRA. And I thought, okay, I will make the flap through that. So it all went very well. But, you know, like when we do toric IOLs, we know our SIA. Here, I had no clue what the SIA through a Hoffman's pocket will be, and he ended up with flattening in that axis, and he needed a cylindrical correction again. So be very careful with these, because an SIA from a normal wound I can calculate. How am I ever going to calculate an SIA through a Hoffman pocket, because I don't do that many of them. And the SIA will be all over the place. It's not like a fixed place. So this is what it looked like. You can see the CTS and everything, but obviously he had flattening and he needed glasses. Then we'll come to some of these problems, like you have keratoconus. Can you do a premium IOL in these people? So again, it depends on how you're going to measure your K. There are various ways of doing it, but I depend on the EKR. If you have access to a pentacam, the best thing you will get is probably EKR at about 4 millimeters or so. And so various ways of doing it. And if you see that EKR actually sort of corresponds more to the manifest cylinder after surgery. So a lot of these people will actually have a sort of a negative spherical aberration. Most of these people with the keratoconus. And so as you can see here, the corneal length is almost 0.5 micron meters. And then most of our premium aspheric IOLs, when you talk about, they have a sort of a negative spherical aberration built onto the lens. So you're not going to use that. It's preferable to use a normal spherical lens, which actually has a positive spherical aberration built onto it. Then there is, we used to think that maybe an aberration-free lens would probably, with zero aberration, would probably be the best. And that was actually good because it doesn't induce any. But then now you have these EDOF lenses, and if you see the type 5 EDOF lens at the bottom, they actually, on purpose, to increase depth of focus, they have a positive spherical aberration built into it. So this is just a theoretical thing. I haven't done it myself. I'm just wondering whether that sort of lens will work better in a person with early keratoconus